if you could pop your name and role and so on in the chat bar, that would be really helpful. Okay, we'll make a start. So,
Sounds grand.
just introduce myself, Ed Gillam. I'm the Interim Head of Profession for Occupational Therapy with Devon Partnership Trust. I also have a role as a Service Manager with DPT. It's a pleasure to be able to chair the session today and introduce the speakers and their presentations. And right on cue, someone started a strimmer outdoors. So hopefully it won't be too disruptive. I'll put my mic off in a minute. Just a couple of housekeeping things. If you could put your mics off when you're not speaking. We'll be taking questions towards the end of the session. We are on a tight timetable today and want to give all the speakers the best opportunity to talk about their presentations. So we'll be taking questions at the end of the session. The session is being recorded and uploaded to the YouTube channel. So Abby can give us details of that shortly. And yeah, introductions in the chat. So I'll introduce Amy Caulfield, the team lead physiotherapist for University Hospitals Plymouth, and also the Equity, Diversity and Belonging Champion for Agile. I've got that right. Amy, over to you.
Thank you so much. Ed, are you happy to pop up the presentation, please? Thank you. So yes, thank you very much for your introduction, Ed. Yes, my name is Amy Caulfield and I am so pleased to present to you all today because I'm so enthusiastic and passionate about being part of a national and regional committee, and I think there are so many benefits to being part of one. So Agile, for those that don't know, is the professional network for the CSP for physiotherapists with a special interest in frailty and older people. And I feel really lucky to be someone who wakes up every morning and loves what they do. And for me, being part of a committee is opportunity rich and rewarding and is a fun role to have. And it certainly has broadened my knowledge and understanding of my profession. So for those of you who may not know, I just wanted to touch on what a professional network is. So it is essentially a network that is recognised by an AHP professional education and trade union body. So that might be the CSP or the BDA or the RCOT, for example. And it's defined as a group of experts in an area of practice that can be clinical or non-clinical. So that might be anything from older people through to stroke, through to our current Agile chair is doing research, but is a clinical physio by background. And these professional networks are self-governing bodies. So rather than being governed by a trade union body like the CSP, they're an independent network or committee. And so the professional network has the ability to choose how to develop and lead the care of patients from a specific population. And as an AHP, obviously, that's a really exciting position to be in. And as we've been talking about this AHP week, you know, it will be you that are key and instrumental in workforce transformation and pathway redesign, and the ones that are inspiring others in particular. So I just wanted to dive a little deeper into the benefits of being part of a professional network committee. What I should say is all these roles, as far as I know, are voluntary. And therefore, at this point, I want to say that I can assure you that my colleagues, who I now also called friends from my professional network, and I had absolutely no idea what to expect. And, you know, it's very normal to have questions about how much do I need to know, how much additional time will the volunteer role take up, and I suppose will I be accepted in this role. And I remember writing my first email to the Agile Southwest committee, and I was so nervous about what to write. You know, I remember meticulously writing and rereading it over and over again because I wanted to write the right thing. And I got the most friendly and enthusiastic and welcoming email back that instantly made me feel part of the committee. And that was back in 2019. So I've been part of the Agile Southwest for a few years now, and that's where it started before I stepped into the National Executive Committee role. And I suppose it really was the start of me realising that committee members are here to support you. And that, I suppose, leads me on to one of the key benefits, which is around what I feel is networking and peer learning. And that's, of course, with like-minded individuals, so people with similar experiences and those that have probably followed a similar path to you who can inspire and support you. Professional network committees also have student roles and associate member roles that again offer that CPD opportunity and guidance and knowledge. And also, you know, being part of a committee and networking opens a lot of doors to other professionals too. So I've had the opportunity to be an associate lecturer for UEA and UCL and do national presentations. So that's all come about through networking, being part of a committee, and just broadens my experience as a physio. Another benefit, so influential role in shaping an area of professional practice. So being part of a committee, you have the ability to input into member engagement and, you know, for example, choose what topics you host for webinars. And it's really around that strategic influence that you have at both a regional or national level, depending on what committee you're part of, for your whole AHP specialist interest. And, you know, as EDB champion, I have the opportunity to influence policy and priorities that are embedded into our daily practice to reflect the population we serve, which is really, really important. Next point is moving on to leadership, growth and development. I really kind of focusing on the 4 pillars here. So that's around your clinical, your leadership, your education and research of more sort of advanced practice as we all continue to develop in our AHP roles. So key things kind of around thinking about clinical. So you've got transferable skills like communication and leadership that you can implement into your daily clinical practice. From a leadership perspective, you know, my role, for example, as EDB champion, I was able to use the experience and the skills I'd learned as part of an application for an MSc leadership development module with the CSP. Certainly learn a lot more about social media skills and using IT as a professional, which I think is really important in this day and age. As I mentioned before, regional teaching opportunities, so that kind of around the education and the networking. And also when we think about research, you know, working with other like-minded individuals who have explored different avenues, you have the opportunity to collaborate. You know, some people in the Agile Committee have been co-authors on academic papers or collaborate on projects with other professional networks and diversity networks. And that's something I managed to do earlier this year with the LGBTQIA, BAME and disability networks. So it's just really eye-opening. And then just thinking about career progression as well. You know, when you look for something that sets you apart from other candidates, being able to talk about the skills and knowledge and attributes that you've developed and learned from being part of a committee really might set you apart from another candidate. And then finally, financial support for education. So being part of a committee, if you were to attend a course or a conference in relation to your role within the committee, then that professional network would be there to support you in terms of funding, travel expenses, hotels, you know, even anything to, you know, stationery and printing if it's necessary for your role. So there's just loads and loads of benefits. So finally, just moving on to how do I join? Well, speaking from personal experience and knowing my colleagues, my professional network colleagues and friends, most started through seeing adverts via regional network emails advertising their roles. And then after being part of that regional committee, they learn what it's like to be in a volunteer role, what's required. And from there, either they were approached through word of mouth by the National Executive Committee, or they then looked to seek out those National Executive Committee roles. What I should say is that being part of a professional network committee, you also need to be a member of that professional network. But the application is usually a very informal telephone call with the chair, and sometimes they might ask you to fill out kind of a one-page profile about what interests you about the role or why you feel you're capable. But what I've learned is you do not have to be an expert or fully understand the role. What certainly you need is, of course, a lot of enthusiasm, willingness to be part of that committee, and of course, essentially to have considered how you may fit in some extra hours on top of your usual working commitments each month. So yeah, those are just the things that I would say are key when you're looking to join. That was a bit of a whistle-stop tour of regional and national committees. I hope that's covered a little bit of what you're hoping for. But yeah, thank you so much, Abby, for asking me to present, and for everyone for listening.
Thanks, Amy. We're going to take questions towards the end of the session. Unfortunately, Amy has to head off at 12:30. So Amy's going to put her email address in the chat. And if you have questions for Amy, want to make contact, find out more, just drop her an email and she'll be happy to get back to you. So thanks very much, Amy. That's great. Now we're going to move on to Jill Hardy, her presentation on, let me just IQ Oro for Swallow Therapy, a service evaluation project. So Jill, over to you. Thanks for joining us, and we'll looking forward to hearing your presentation.
I'm just wondering whether, so I've got the presentation here. Do I load it from my end? Sorry, I should have sorted this out before.
You can do that,
yeah.
Or I can do the share. It's up to you.
If you're happy to share them, I'll just let you know when to change the slides. That's probably easier I'm not so technical.
Okay.
So yeah, so I'm talking, first of all, thank you very much for the offer to speak today. It's great to be amongst a whole group of varied AHPs, and for us as speech and language therapists to be able to talk a little bit about some of the work that we do. And this presentation is about a relatively new therapy treatment for swallowing called iCoro. And how we as a service here in Exeter were able to get involved in a sort of a small research project or a service evaluation. So if we can move on to the first slide. So iCoro I heard about it first of all at a special interest group back in 2019, a special interest group for speech and language therapists working in the area of acquired brain injury. And I was really intrigued. A therapist presented about being offered this device, which looks like this, as a new potential therapy for swallowing, patients with swallowing disorders. So it's a small neuromuscular training device that patients can put in their mouth. It's a bit like a mouth guard with a handle. And if you train with it against resistance 3 times a day, iCoro claimed that 97% of people will have an improved swallow as a result. So I was really intrigued by this claim. It seemed too good to be true. However, if patients were going to have the potential to benefit from something that seemed so simple, I also was intrigued to maybe be able to have a go at trying it ourselves, and I'll come on to that in a moment. The device has been developed in Sweden by a doctor and who a dual-trained doctor dentist who became interested in patients who were presenting with swallowing difficulties. And her research, which is extensive, has helped the device become part of fairly standard swallowing treatment in Sweden. But it's relatively new and not well understood here in the UK. It works by improving lip strength and stimulating a sensory neural arc to the brain to influence lots of muscles and the sensory pathways involved in swallowing right through the swallow tract. In May 2019, NICE actually issued a medtech briefing showing interest in this new device for swallowing. So it's not a recommended treatment yet in the UK, but there has been some interest. And as part of that briefing, they identified that there was real potential. However, that there were some concerns about the standard of the research that had come out of Sweden in terms of numbers, and there was at that point no randomized control trial yet, but it showed potential. Next slide, please, Ed. Ed, could I have the, thank you. So, as I said, I was intrigued, and I asked the reps from iCoro to come and demonstrate it to our department here in Exeter. And because it potentially was an innovation in swallowing therapy in the UK, I think my excitement spilled over, and they offered for our department to take part in a trial of using these devices in an NHS setting in the UK. And they offered us 30 free devices to use with our patients. In return, they asked us to provide some feedback about what it was like. Is it something that speech and language therapists in the UK would find useful? Is it easy to put it into our practice alongside our usual dysphagia management? Did our patients like it? Would we be able to find funding? All those sorts of questions. So we became part of this early adopter program, specifically looking at the use of iCoro with patients in the UK. Having received the devices, we then had some training for our therapists, and we then devised some specific criteria for including specific patients into our project. And kept admin for that to keep track of that information so that we would be able to provide that feedback at the end of the project. Next slide, please, Ed. So what started off as just us using these free trial devices and giving iCoro, the company that produced the device, some feedback, it felt like we had an opportunity here to maybe be a bit more precise about how we were using them and look at the outcomes. And so I contacted the research department within the trust for some advice, and was pointed in the direction of the Southwest Academic Health Science Network, who at that time were, their main brief is to look at innovation and service developments. And they were interested in this project. This was just before COVID hit. And there was some money around, and we were offered support to help design and run the evaluation, as well as a grant. And that grant we were able to use to pay one of our therapists for some extra hours to support the administrative side, whilst I was sort of leading on the clinical side. And that's really helped us change something that was quite informal into a much more formal service evaluation project, and have an opportunity to sort of touch our toes, dip our toes into research. One of the unique things about our early adopter site in Exeter was that we were using iCoro across the whole pathway across acute rehab and community, and that's why iCoro were particularly interested in our feedback, because they would then planning to feed that back to NICE to see whether or not iCoro could become a recommended treatment in the UK. I was more intrigued just to try it out for myself with our patients and to see whether or not the claims that iCoro made for this device were really, whether they would stand up. And because if so, why wouldn't everybody be using it if it really had such brilliant results? So yeah, we were trying to understand the impact of iCoro for our patients, but also how it would fit into our service delivery to be able to provide that feedback. And we were particularly interested as well to check out the influence of spontaneous recovery, because we wondered whether that was having an influence on iCoro's own claims, whether they were in Sweden introducing this device very early on post-stroke or brain injury, and capturing that sort of spontaneous recovery period. Next slide, please, Ed. So we carried out the service evaluation. In the end, we managed to get 25 patients onto the program, and 21 completed the full training, which takes about 12 weeks. And so we had results from 21, and the researchers at the Academic Health Science Network conducted the analysis of all the results, and using these were all the outcome measures that we used at the time to measure the impact that iCoro might be having. And we were really pleasantly surprised. We'd already started to see some really positive outcomes for some of the patients, but we were really pleasantly surprised as well that, in fact, on analysis across the whole 21 set of 21, we were getting statistically significant improvements across a whole range of outcome measures. We were particularly interested in seeing whether people's functional swallowing improved. So were they able to go from non-oral feeding back onto oral diet or drinks? Were they able to go from modified diets like pureed diets back to more normal food? Were they able to go from thickened drinks to normal drinks? So that was really important. But also, did this have an impact on their quality of life and of their experience of eating? Did it allow them to participate more in social situations that involve eating and drinking? So we had a large range of outcome measures, and these were all the ones in which we saw improvements. And so that really supported the idea that iCoro is something really positive that we would want to be having access to for our patients. It definitely didn't help everybody, and that's something that we're now quite interested in, is to really hone down which exact patients does it support best. In addition to these results, we also canvassed the speech and language therapists who were involved, whose patients were part of the evaluation. And generally, the feedback was really positive. They found the device easy to use, easy to introduce to patients. There were very few contraindications, and most people would recommend it to other therapists, or would want to be able to use it again in the future. And we also canvassed patients and what their impression was, and it was very similar, that those who were using it found it quite straightforward, and it didn't take up a lot of time in their day to be able to use it. Ed, next slide, please. So thinking about the impact that this service evaluation offered us, and perhaps some of the challenges going forward. As a department, and from a personal point of view, it was really great to be involved in research. Even though this is not a full-blown research project, it was a service evaluation. It was something that, with the addition of the grant money that allowed us to have a bit of extra therapy time, was something that we were able to do within our clinical day-to-day working, and had a direct impact on outcomes for our patients. It did take more of my time than I was expecting, so quite a few extra hours probably put in there, but it was also stimulating to be able to think about a new treatment in this way, and to explore it for ourselves, whether something actually is beneficial or not. Since the service evaluation finished, we've been trying to look at sharing that learning. So we developed a poster which was presented at the 2021 UK Stroke Conference, describing the service evaluation in detail. And if anyone is interested in kind of having a more detailed summary of what we did, I'd be really happy to send a copy of the poster by email, and that describes it in a lot more detail. And And as a result of having the research analysis demonstrating the positive effect of iCoro, I think that really reassured us that even if the claims were perhaps not as strong as the company wanted us to believe, we definitely saw enough benefit to know that this is something that we want to have access to as another tool in our toolkit for swallowing management for our patients, and something that we would want to have access to both in the acute and in the community for patients. However, our evaluation, the numbers that we included in it were similar to a lot of the studies that were coming out of Sweden. And so there's still this question about there needing to be more research. There has been a randomized control trial in Sweden since we started all of this. But even then the numbers were relatively small. It was 116 patients. So there's still very much a drive to try and have perhaps a study looking at iCoro in the UK. Most of the Swedish research is around stroke patients, but across our pathway of speech and language therapy, there are a lot of other diagnoses that we feel may benefit from iCoro, and it's trying to understand from our results which patients does it help the most. There are also challenges to how we're going to fund this going forward. We had 33 devices. They cost £116 each. And they are single user. So once we hand one to a patient, we can't use it with another patient. So there was some, we were hoping that they might become available on prescription, but that is not possible at the moment. And so we are looking at how as a department we can perhaps get a business case together to try and fund these on a more regular basis. And at the moment we're funding them through our own department. So it's been really great to be part of research, to get involved in innovation around options for our patients. And from a personal point of view, it was, as I said, interesting to have some time set aside to get involved in research, something I hadn't had an opportunity to do earlier in my career. So thank you very much for listening. And as I say, if anyone wants more information, I'm happy to be contacted, or I can send a copy of the poster. Perhaps there's somewhere where we can have that on display. Thank you, Ed. Oh, I think there's one more slide, which is references. Again, if anyone's interested, that will be available with the slides when they're shared. Thank you. Ed, I think you're on mute.
Thanks, Jill. Some very interesting work, and we'll come back towards the end of the session if you're able to stay on for any quick questions. But if you could pop your email address in the chat bar, then and if there's anyone who wants to contact you to follow up, they'll be able to do so. That'd be great. Thank you.
No problem. Thanks.
We're going to see you, Amy. We're going to move on now to Justine Tansley, who's going to be talking about vascular podiatry, a developing specialism. So thank you, Justine. Over to you.
Thank you. I'll just share my screen with you.
Yeah.
Can you all see that? Is it sharing? Perfect. Okay, great. Lovely. Yeah, so my name is Justine Tansley. I'm a podiatrist with Torbay and South Devon NHS Foundation Trust, and my area of specialism is vascular podiatry. So the role of a vascular specialist podiatrist is a relatively new one. So although vascular assessment has always been a really core part of what we do in podiatry, it's only really been the last few years that we've realised and recognised that there's probably been a need for change, which is what I'm going to talk about this afternoon. So I thought I'd just start with a really brief introduction as to the main condition that we're interested in as vascular specialist podiatrists, and that's peripheral arterial disease. So just very quickly, peripheral arterial disease, or PAD, as we'll refer to it throughout the presentation, is a condition which affects the outer arteries of the body, so such as those that we find in the legs and feet. So the arteries can become narrowed by fatty deposits, and hence the blood supply can be reduced. So it's estimated that about 20% of people aged over 60 in the UK have PAD, which equates to about 9% of our population. So poor management of PAD can lead to things like heart attacks, strokes, or amputations, and maybe even early death. So earlier on this year, NICE updated their recommendations for the management of peripheral arterial disease, and they suggest that patients should be offered an assessment for PAD if we suspect that it's present, and patients should be given information about their disease and how it can be managed. So this just seems to fit in really well with what we were already doing in podiatry, and it's just felt like a perfect opportunity to go further as a profession really with this. So as I said earlier, lower limb vascular assessment has always been a really core part of what we do in podiatry, particularly at that first assessment. So it's quite likely that everyone we see, when a podiatrist first sees someone, they'll probably try and feel for a foot pulse, maybe listen with a Doppler to that arterial sound, little handheld Doppler device. And it's just those really kind of, basic, simple tests that can actually give us a really good idea of what's going on with someone's peripheral blood supply. But I think, like with a lot of professions, the podiatry profession is also changing. So we're starting to prioritise patients now with complex medical needs, which are a threat to kind of lower limb health. So conditions like diabetes, peripheral arterial disease, which can result in complications such as foot ulceration and gangrene, which can ultimately lead on to things like amputation. So again, I think we've realised as a profession that there's this unmet need for those patients who have peripheral arterial disease, and we could probably be doing more to manage them before the point where they actually need surgical intervention. Okay, so what are we doing where I work in Torbay in South Devon? So I'm really really lucky to say that we've have a fully commissioned vascular podiatrist post. So, I'm very privileged to be the first vascular podiatrist employed by Torbay in South Devon Podiatry Department. And my role is to develop a kind of vascular specialist element amongst an already kind of quite well-established podiatry service, but also to kind of find out what the wants and needs are of the patients and the team there. So the first thing that I discovered was the team actually just wanted some training, some support from somebody, like an expert, someone that they could go to as kind of like a sounding board regards to anything vascular related. So we've delivered or started to deliver training now to give the team more confidence to say whether they feel peripheral arterial disease is likely or unlikely in the patients that they're assessing. But I think it's also worth mentioning that the podiatry department receive approximately 150 referrals a week, and about half of those are for diabetes or vascular related conditions. So again, it just felt like a huge opportunity to obviously not only upskill our podiatrists, but pick up on those patients from those referrals that do have PAD, and just offer them a more in-depth assessment and give them some advice. So this is where we the new vascular assessment clinic comes into it. So we've developed a new clinic, and the purpose of that clinic was to explore the cause and severity of peripheral arterial disease in the patients that we identify. Offer those patients advice on the management of any risk factors, and ensure that we're seeing the most kind of at-risk patients in a more timely way and actually set them on the correct treatment pathways. But it's also a really nice opportunity to make sure that we're working in a more kind of integral way with their GP and other specialist teams who can give us support with their treatment plan. So our podiatrists have been given a really clear referral criteria for that vascular assessment clinic, so they know exactly the types of patients that they should be referring in, that need that kind of more in-depth assessment, and they're also familiar with the types of patients that perhaps aren't suitable to come along to the clinic too. Okay, so this is the model. That it's kind of still in development, but we're piloting it at the moment. So we have a kind of one centralised specialist clinic, which is based at Paignton Health and Wellbeing Centre, which is supported by 3 absolutely fantastic assistant practitioners. So they're the ones that carry out all of the clinical tests, if it's indicated, gather all the kind of information, and the clinic's also supported by a vascular specialist podiatrist who's there to support the interpretation of the results, individual care plans, and make those onward referrals if they're needed. And we're all we've managed to develop, and we're all now working from a kind of standardised, evidence-based procedure now. So once the patients had all their tests, we can then offer them that kind of tailored advice. So advice specific for them according to their results, their specific risk factors, and offer them any lifestyle advice to improve their cardiovascular health. We report the results to their GP, and we can also ask the GP as well if they can support us to manage any cardiovascular risk factors, and that might include, for example, a medicines review. So, and then from there, we'll come up with a plan so we can refer onwards if we need to. So it may be that that person could be managed actually within podiatry, depending on the problem they present with. So we have lots of specialist clinics within podiatry that we could kind of direct them to. But there are also lots of other established pathways that we're already linked to, that can support us with that patient's lower limb health, that we could refer them to as well, and do a little bit of shared care to improve their lower limb health. Okay, so the results so far. So we've only kind of had the clinic up and running for 4 weeks, so it's still fairly new, but we've managed to achieve 25 holistic assessments in the last 4 weeks, and out of those assessments, we managed to rule out peripheral arterial disease in 13 patients. So that's really good news for those patients. And 12 of them, we found that they did have PAD to some extent. So it varies quite widely, but we were able to give them, a specific care plan and specific advice, tailored to their needs. We did find one person who had suspected critical limb ischemia, so we urgently referred them direct to the hospital, straight from our clinic. We tend to be finding that leg or foot pain is the most common reason for referrals so far, although I'm anticipating this might change now that we've done lots of training with our podiatrists. So it'll be interesting to see whether the referrals change over the next few weeks. And also we're finding that we're discovering things sort of opportunistically by assessing the patients. So we're finding things like picking up things like atrial fibrillation, for example, which left untreated, could potentially lead to stroke. We met a chap who had quite a lot of significant unplanned weight loss, so we've managed to refer him to his GP for more investigation. And something which is quite common, we pick up things like mental health issues, so we can signpost those patients to places where they can seek help with those things. So just moving on to the future. So one of the key recommendations in the NICE guidance was actually to offer a supervised exercise program to those patients with intermittent claudication. So intermittent claudication is a type of ischemic pain which can present in the leg, which is links with peripheral arterial disease. But those types of exercise programs aren't currently available locally. So what I'm doing with my vascular assessment clinic is actually recording the number of patients with intermittent claudication that are presenting, just to kind of see what the prevalence is really, and just see if we can perhaps make a case to start our own exercise program. Maybe, you know, we don't know. I'm also monitoring the time from referral to assessment. So some of our assessments are quite time critical. So I think it's really important just to ensure that those assessments remain timely, and just to kind of monitor that. I'm going to continue working with the podiatrists just to ensure that they're following up from the advice and recommendations that we've been giving the patients and the GPs, to see whether or not they're taking it and what the outcomes are, and just kind of continuing to listen to what the wants and needs of the patients are and the clinicians, just to kind of develop the service further. So it's just the tip, feels like it's the tip of the iceberg really, just a little snapshot of one of the things that we're doing to develop this kind of area of the profession. But yeah, so, you know, who knows where we'll go next with it. So watch this space. But thank you very much for listening.
Thanks, Justine. Yeah, another fascinating presentation, and really new service. So good luck with that and developing your new offer. That's great. Again, if you could just pop your email in the chat bar, then if we don't have any time for questions, people can be in touch. That'd be really helpful. So our final presentation today is from Lisa Butler and Lisa Roberts. They'll be talking about the value of interdisciplinary working with functional neurological disorder. Thank you both. Over to you.
Hello, I'll try and share my screen. Here we go. Let's hope it works. Okay, so can everybody see that?
No.
Oh.
Not yet.
Oh dear.
Do you want me to have a go?
Yeah.
Okay, hold on. Nearly there. Hold on.
Sorry. I think I've done window rather than screen. I think that's probably where I went wrong. Great. Okay, so nice to see so many different AHPs. My name's Lisa Butler. I'm a physio and I work with Lisa Roberts, who's a speech and language therapist, and we both are based in Exeter. And we've been involved in developing the FND pathway in Exeter and helping to spread the word about FND with our colleagues, mainly in the community, but also a little bit in the acute. Next slide, please, Ed. So just a little bit of history about our service. Oh, sorry, on to Lisa.
Yeah, so we just thought we'd start out before Lisa talks about our service. We give you a little bit of an introduction about what FND is for people that are not familiar with it. So it's a set of neurological symptoms which are caused by disrupted functioning in the nervous system. So it results in a wide range of symptoms, and they really differ from person to person, so every person is very different. But they, just to give you an idea, they can include things like movement disorders, tremor, seizures, communication disorders, swallow disorders. It's not caused by disease or structural problems in the nervous system. It's a problem with the way the brain communicates, the way it communicates with itself, so between different networks within the brain, and the way it communicates with the rest of the body and the outside world. It's not a diagnosis of exclusion, so it does behave in a very specific way, and that means that it can be diagnosed by using positive signs. It's pretty common, actually. and becoming increasingly known about, but it's actually the second most common reason for people seeing a neurologist, and potentially very costly as well. So recent estimate put it as medically unexplained symptoms as being 10% of NHS expenditure in working age populations, and that's because without treatment, people will access multiple different services, need lots of investigations, scans, and often lots of hospital admissions. Next slide, please.
Right, so now a little bit of history about our service. So around about 2016, the Devon Partnership Trust developed a psychological medicine approach focusing on conditions that fall in the gap between physical and mental health services. And the community neuropsychology service dedicated a small resource to work with FND, and this was headed by Dr. Leo Russell. And he collaborated with his therapy colleagues. We tried out a few initiatives, one of which I was involved in, which was a project trying to prevent admissions going into Modern Neuro Rehab Centre, which was really successful. And then following a regional conference in January 2020, we set up a virtual MDT that summer, and that was in between the COVID waves. And this was to problem solve some of our very complex FND patients and also to develop the FND pathway. And so we had a bit of a patient side of the meeting and a business side. And we meet twice monthly and invite others to come and discuss their really complex patients. And we published our pathway this summer. Next slide, please, Ed.
So in terms of how we approach treatment, there have now been consensus recommendations published for physiotherapy, occupational therapy, and most recently last year speech and language therapy. So we have got a really sort of solid basis for how we as individual clinicians work with the patients, but as yet there is not that much evidence about the best way that those services should be structured together. So it is widely acknowledged in the literature that any approach with working with FND should be holistic, it should be interdisciplinary, and it should be based on a kind of the biopsychosocial framework. So as part of our work in that MDT, Lisa and I particularly have been looking at how we can kind of work together and establish that within that Exeter model. So you can see here from this diagram here that the individual core symptom that was displayed that led to the diagnosis is only actually a really small part of everything that needs to be addressed. So that means that we need to work really closely together. It's a really different way of working than our usual neuro rehab patients. So what we thought we'd do to give you a sort of flavour of how we work together with these patients is just to present a short case study of somebody that Lisa and I have both worked with together. Next slide, please.
So we'd like to introduce you to Julia. And the history started for her in October 2020 following a cardiac ablation which failed. Following this, she developed right-sided leg weakness and was falling. This gradually increased, she deteriorated, and in May 2021 she was admitted to the RD&E with bilateral leg weakness, hyperglycemia, and she had a really unusual voice that sounded a bit like a whining 6-year-old from the Midlands. So very unusual. She was in hospital for a few days and came out then to the care of the UCR team. So had quite a bit of input there from services. She was then referred on to my team, the community neuro team in Exeter. And after seeing her, first of all, she was like set up downstairs. It was a bit chaotic at home. She was hardly moving. She was catheterized. We referred on to speech and language therapy and also our FND psychology colleagues. We started immediately, as we do with all our FND patients, on education on the mechanisms, and also looking at lifestyle factors. And for Julia, sleep was a major issue. She was only sleeping 3 to 4 hours a night, and this had been going on for a long time. She was drinking a cup of tea every hour, and she was also still trying to work as a self-employed accountant, and so really pushing herself hard. Her sugar levels were extremely high, but actually she took on board our advice really early on, and after about a week she was sleeping 8 to 9 hours a night, and she'd had her catheter removed after a couple of weeks. So after that sort of initial advice, we went on to work in a more uni-professional way. For me, as a physio, that was getting Julia to move with diverted attention, breaking down movements into component parts. The OT looked at pacing and fatigue, and later on down the line, I actually used hypnosis with her as an adjunct to the usual physio, and that was to good effect. Next slide, please, Ed.
So this here is a table which we often use with our patients to help them to kind of see the complex picture of factors that have led to their FND, and it draws on that biopsychosocial framework that I mentioned earlier. So you can see that there's a kind of almost scene setting stage in terms of the vulnerabilities. So it's kind of what risk factors have they got, what things have made them more likely to develop FND in the first place, and then it goes on to what mechanisms actually triggered the symptom to express itself, and what factors there are that perpetuate the symptoms or prevent them from being able to get better. I'm not going to read it all out to you, all the different bits, but you can kind of have a look at it whilst I'm talking. It's not necessarily as clear cut as this table makes it seem. So there are often lots of overlapping factors. So, for example, stress was a big factor for her. That's actually likely to have been a contributing factor to her developing cardiac problems, which then became a biological risk factor for her. And lots of the precipitating, so the things that triggered her symptoms were still present as things that were continuing to drive the symptoms later on when we got to meet her. But nevertheless, it really helps us as clinicians and also patients to be able to order thoughts about the condition and understand that it's not one thing that's caused FND, it's a whole complex picture of different things. So as a team, we are looking to address as many of these factors as we can, and to then weave that into the direct work we're doing on specific symptoms. So what we need to do as a team is to look to reinforce and kind of build on what each other is doing, rather than all duplicating the same thing. So and I think that EPIC has really helped us with this. Actually, this is one example of somewhere where it's made life so much easier for us to be able to be aware of what each other's doing within our sessions. So as an example, very early on for me, I was able to see what Lisa had done and then direct my questioning. So Lisa and Julia together had recognised that stress was a significant factor. She was very much on board with that, understood how that worked. But because her life and the situation was so kind of chaotic, she just hadn't been able to do anything about addressing that. So Lisa had talked to her about meditation, but she hadn't been able to do anything to take any steps towards that. So I was able to build on that a little bit in the next session, actually did a meditation with her and helped her to download an app onto her phone so that she could take that on and be independent with that going forwards. So we then sort of carried on staying in touch as a team on EPIC. Although we were working individually with her, we were staying in touch and also by email with the psychologist so that we could make sure that we're addressing these perpetuating factors between us, and also supporting each other with kind of profession-specific expertise where that was relevant. So, for example, with her communication difficulties, there were quite a lot of psychological factors involved in that, and so it was really important for me to have guidance from the psychologist to support me with that. So she's not quite there yet, but she has made absolutely massive progress. She's learned how to care for herself. She does her meditation every day now. She's got back to riding her horse, which was a massively important in her life. She started swimming. She sounds much more like herself again in terms of her voice and her speech, and her swallowing difficulties completely resolved. She's been hugely grateful to us as a team. And she says that along the way, she's learned so much about herself, and she even said recently that she's almost glad of FND because it's helped her to kind of face up to some things, address some things that needed addressing, and she's really transformed her life as a result of it now. Next slide, please.
So in summary, we've found that interdisciplinary working with people with FND is really, really valuable, and it's key to give timings of interventions or different professions. This will be different with every patient. It might be that you need some psychology before you have any other interventions with other professions, but it will be different. So we need to be talking to each other. Having a consistent approach and providing the same message builds the patient's confidence in the interventions, and it also reinforces a message. You're more likely to gain patient activation and engagement. Working in collaboration with each other ensures we don't duplicate some of the generic therapy tasks that you have to do within FND. And it's also helpful dividing up some of the workload because there's always a lot to do with these patients. It also gives us much needed peer support, and more importantly, we actually learn loads from each other and increase our expertise. Next slide, please, Ed.
So that's really just the end. The next slide is just our references for anyone that's interested in finding out more, and there's a couple of websites there which have got fantastic information on about FND, and if anybody's interested. So thank you very much.
Thank you.
Thank you both. What a great example of AHPs working together, but also working across organisations, because I think I heard that DPT were instrumental in setting up or working with RD&E to set up that service. So fantastic service and great team working. Thank you. We just have a couple of minutes left, and if there is anyone who would like to ask any questions or make any comments, that would be great. Anyone who would like to come in? No. So Lisa, if you could just pop one or both of your emails into the chat, that would be great to give people a point of reference if they want to find out more. But I think we will draw things to a close. Thank you to Abby and Matt and the faculty for bringing together these sessions. There's 2 further days, noon tomorrow and noon on Friday. AHP Day itself is the 14th, this coming Friday, and I'm sure there'll be a lot going on. And yeah, thank you ever so much, everyone, for your time. And thank you very much to our speakers. Take care.